Bismillahirrahmanirrahim. Good afternoon, all. Thank you, Mr. Chair. Thank you for the Diabetes India organizing committee. Thank you for Banshi and all the team. And special thanks that this is, session is addressed under the Diabetes in Asia Study Group, being the immediate past president of Diabetes in Asia Study Group. I am proud to share in this session and participate. And the previous talk facilitate my mission because we are now talking about the cardiorenal metabolic syndrome, and this is my disclosure, and this is the references if you want. And why we are talking about cardiorenal metabolic syndrome? Why is this term now? Because there is a high prevalence of this constellation of affection of metabolism and linked to the cardiovascular and the kidney, and affecting at last the quality of life of our patient. So we need to think outside the box, because there is growing interest. Now we see many medications can facilitate the mission, but first we can realize that whatever the starting point, whatever, if it is in the metabolism, type 2 diabetes, obesity, or it is in the cardiovascular, or it is in the kidney, always not go to Rome, but go to the constellation of cardiorenal metabolic syndrome affecting our patient. So we see that every detailed item must be addressed in our patient book, and this high prevalence and increased mortality and morbidity and reduced survival. Look for this. If diabetes alone, we lost about 13 to 14 years with earlier onset of diabetic complications. If diabetes and the chronic kidney disease combination, we see the mortality to be 31%, mostly 3 times any one of them alone. And this reduced survival and reduced also quality of life, making us must look in depth for the pathophysiology of the cardiorenal metabolic system interconnected, and whatever the starting point, it will force the sequence to develop the others. But noting this slide is very important, because staging of cardiorenal metabolic syndrome now starting from 0, not from 1. And also the prevention must starting at this point. So stage 0, we have nothing. We have no risk factors, but we want to prevent this risk factor, because adiposity is there. And the adiposity is the key. All of the speakers today and yesterday and tomorrow also, and whatever the topic, they said that adiposity and the obesity is the most prominent thing that can lead to the diverse quality of life and the morbidity and mortality. So stage 0, we have no risk factors. Stage 1, we have starting exists ectopic adipose tissue. Whenever this adipose tissue is located ectopically, either pancreatic or in the liver, like the previous presentation, or in the epicardium or anywhere, it floods the circulation with inflammatory mediators and causing histological and functional alterations that lead to target organ damage. Stage 2, we have the metabolic risk factors, dyslipidemia, especially triglyceride, hypertension, diabetes, and all the aspects of metabolic syndrome. And if we have also chronic kidney disease, neither due to hypertension nor due to other risk factors, but only metabolic. Stage 3, we have the subclinical cardiovascular disease. We have the renal affection. We have a very high risk patient to go on the other way of cardiovascular and renal affection. Stage 4, we have the clinical overt cardiorenal metabolic syndrome. The value of this staging, not only to know where we are and how to stratify our patient according to the stage, but also these stages are interchangeable. Think that if we are starting early in stage 1 or stage 2, we can stop going to stage 3 and stage 4. And this is a very important issue, that early, effective, holistic approach must replace the fragmentation of care. Here is the fragmentation. All the time we were said that to control diabetic complication, you have the ABCs. You have the lipids, diabetes, and cardiovascular. But now we have all this constellation together. We need the hepatologist, the cardiologist, the nephrologist, the dietitian, weight management, all in one. So all in one can be translated clinically to team approach, and this is must replace the fragmented approach that take only one entity. Debates that glycemic control may decrease the complications or not, dyslipidemia or also. So these debates must be going on, and we must concentrate on the holistic approach. We must address all the areas. So this rationale of staging, that we can know where our patient is, and also we can know whatever the modalities that can address the current status of our patient to prevent progression and sequential decline of the target organs in this modality. So screening of cardiorenal metabolic syndrome is very important. But here also, I remind you that biological screening or traditional screening, including body mass index, waist circumference, and the components of metabolic syndrome, and the muscle and renal functions, and all the labs are not enough. We are now must looking for what is called social determinant of health. In our communities, especially low and middle income communities, we must address this: food security, housing instability, finance, access to care, transportation challenges, employment, health literacy, social isolation. All these must be screened in every patient. So, not to go to prescribe your patient a medicine that can be not be affordable to him. Not to go to advise your patient against his social context. But you must know this. So this is modality of screening must be in mind. And according to the stage, we can screen annually for stage 2 if we have, remember that stage 2 have the starting of the adiposity, or for CKD, 2 to 3 years for stage 1, 3 to 5 years for stage 0. Stage 0, remember, stage 0 have no risk factors, but we want them not to go to this cardiorenal metabolic club. To prevent them from entering this club, you must do this first. So, starting early life, as you see, the traditional before we are starting to investigate our type 1 diabetes after 5 years and type 2 diabetes when diagnosis. No, if the patient is at risk, we can start so early at the age of 3 years or 9 years. So everything is changing now. It is your patient that dictate what you will investigate and what you will screen for and how to stratify him. And again, the social determinant of health, as I said before. So we need risk prediction, whom we will screen, because as all of you know that there is no universal screening can be accepted neither on the context of science or social or finance. So one of unmet needs remains that we don't have prediction or predictor algorithm that who will be screened, except sometimes they said about the renal functions or the social context or the obesity or familial dyslipidemia. But still, up till now, we have no Framingham score, we have no score 2D, we have no like this. So the risk prediction remains a challenge. And as I said before, this approach to the cardiorenal metabolic syndrome, instead of being fragmented care, we must have coordinated care. And according to the stage, if we are starting from stage 0, our intention is to increase exercise, leave away the sedentary life, and preventing weight gain. And the obesity prevention is the first one priority. And here you start early, even for the maternal health, because when you are caring for the mother, the offspring will come also in a good health and away of the risk factors. So you must start as early as possible. Stage 1, excess of dysfunctional adiposity, also decrease weight, lifestyle changes. Sometimes lifestyle changes cannot be as effective as we want all, but don't neglect it. But put it and put on the table also the pharmacological approach. Especially we have now weight management drugs like GLP-1s and SGLT2, and we can go forward for this. Even if it is necessary, you go to the bariatric surgery. But don't leave your patient even in stage 1. And in stage 2, you must address the established risk factors like weight, like hypertriglyceridemia, hypertension, chronic kidney disease, using all the weapons, either pharmacological or non-pharmacological. And this must go to the goal that you prevent your patient from going to the stage 3. Stage 3 is the subclinical, and the subclinical we have tools, especially coronary artery calcium can be valuable at this stage, and we can define the stage of heart failure subclinically before it goes, and also the risk for chronic kidney disease, and we can manage accordingly. If these stages went away from your hands and you are faced with your patient with stage 4 that you already have cardiovascular disease and chronic and without chronic kidney failure, the goal of management is to optimize the care for secondary prevention for your patient for CVD and prevent the progress to the failures, either heart failure or kidney failure. And in all of these patients, the pillars, all we are known. We can use all our weapons like beta blockers, angiotensin receptors, neprilysin inhibitor, mineralocorticoid receptor antagonist, and the SGLT2 inhibitors in patients, especially if there is heart failure, even with reserved or reduced ejection fraction. So GLP-1 and SGLT2 are markers. Here are our weapons. Look for every one of these modalities can do more than one job. And I think the question mark about tirzepatide in chronic kidney disease are now cleared by the recent research that they are good for keeping the patient away from progression of kidney failure. But SGLT2 have metabolic, cardiovascular, and renal targets, and GLP-1 also, and mineralocorticoid receptor antagonist, and tirzepatide, as I said. In diabetes management, the priority to these drugs that can prevent progression of cardiorenal metabolic, the protection of the target organs from damage, and also lead to glycemic control. But if you are faced by a progressive stage of chronic kidney disease, SGLT2 inhibitors here to delay the regression, the progression of glomerular filtration rate, but make another anti-hyperglycemic adding to this because glycemia will not be controlled. So interdisciplinary care is most important, and my message that education is very important. And here we are developed in MENA region, IDF, an educational program for cardiorenal metabolic disease, and this will include the 7 modules in agreement with the diabetes school of IDF, diabetes school, and will be propagated soonly, launched at the next quarter of 2025. My take-home message, Mr. Chairperson, cardiorenal metabolic disease now have very succeeding prevalence, and we need holistic approach to entail every detail in this syndrome, and we must consider the social determinant of health when screening and when treating and when facing our patients, and the availability of effective approach address adiposity, and the pharmacological and bariatric surgery are there. And thank you very much.